My talk today is an overview of POTS, and hopefully I'll help interweave how all the other excellent speakers today are involved with postural orthostatic tachycardia syndrome. Okay, that's who I am, and you can read all about me on my slides later on. You heard a little bit about me already. Okay, let's start off with the definition of POTS, postural orthostatic tachycardia syndrome. Basically, this is a issue where you have a collection of symptoms that are usually orthostatic intolerance type symptoms that exist for at least 6 months duration. Now, different investigators use different time frames. Some use 3 months, some use 6 months, but the JAC focus paper here used 6 months duration. One part of the definition that is not really of dispute is the rise in heart rate of 30 points upon standing within 5 to 10 minutes upon standing. And that's 40 points if you're under 19 years of age, 12 to 19 years of age. And the other part of the definition is that there should not be any drop in blood pressure when this happens. And so that's usually defined as nothing less than 20 millimeter mercury drop in blood pressure. So you should have frequent symptoms upon standing: lightheadedness, palpitations, tremulousness, generalized weakness, blurred vision, exercise intolerance, and fatigue. Okay, so you might notice that there's absolutely nothing, no part of the definition that actually talks about dysfunction of the autonomic nervous system, dysautonomia. Okay, so we are going to start from the beginning here and build upon what starts as dysautonomia to understand POTS. So we're going to talk about dysautonomia, even though it's not even part of the definition. And it's important to understand that POTS and dysautonomia are not synonymous, and a lot of us kind of use it as synonymously oftentimes. And POTS is not even really a subset within dysautonomia, and a lot of us think of it that way. By definition alone, you can see that POTS can actually stand outside, independent of dysautonomia to some extent, at least theoretically. So POTS has a portion that does not involve dysfunction of the autonomic nervous system at all. Having said that, we're going to start with trying to understand dysautonomia. Dysfunction of the autonomic nervous system. Everyone knows autonomic nervous system made up of parasympathetic and sympathetic parts of the nervous system. And we usually are talking about a dysfunction of the parasympathetic nervous system when we're talking about dysautonomia. Something's wrong with the parasympathetic portion for the most part, or at least in the beginning. And when we're talking about dysfunction of the parasympathetic nervous system, for the most part, we're talking about the vagus nerve. It's the main part of the parasympathetic nervous system. And the vagus nerve ends in nerve termini that secrete acetylcholine. So in some respects, dysautonomia is a abnormality of the production and activity of acetylcholine. For the most part, a paucity of acetylcholine, but it could be a poor distribution of release of acetylcholine. Some places too much, some too little, but overall deficit. Lots and lots of underlying etiologies that can lead to dysautonomia. And I've got them categorized here. I'll point out a few. Dysautonomia can occur just as simple as deconditioning, being inactive, and even just part of normal growth. So mild dysautonomia can be expected just as part of normal growth, just as part of deconditioning, and in fact, a part of excessive exercise training. Astronauts that go out into space become dysautonomic simply because they're inactive in their space capsule. Nutritional deficiencies, leaky gut, things that have to do with the GI tract, concussion, sometimes sinus surgery has led to patients being dysautonomic. Then there's the infectious etiologies, Epstein-Barr virus that causes mononucleosis, creating maybe a chronic mononucleosis, can cause dysautonomia. I think in my area, molds and mold toxins are something that I think a lot of my patients become dysautonomic from. Then there's the stealth infections. Occasionally we see a patient become dysautonomic after a vaccination. Then there is the issues that arise from being hypermobile. And there's various ways that what I call viscerotosis, sagging of organs, that can lead to dysautonomia. And finally, autoimmunity, such as blocking antibodies blocking acetylcholine receptors. And finally, mast cell activation syndrome, which Dr. Afrin will talk at great length about shortly. Now, those slides were made prior to COVID. Now, with COVID being around, a huge portion is due to COVID-19 and post-COVID long haul syndrome, as Maria Seeley will talk about a little bit later. Occasionally, with the COVID vaccine, we'll see dysautonomia as well. I've kind of categorized these etiologies in a different way: top-down assault, full body, we're talking about full nerve body assault, and bottom-up assault. So things like concussions and craniocervical instability and intracranial hypertension or CSF leak. These are all things that are starting up high near either the vagus nerve nuclei or just as it leaves the skull, and vagus nerve can become injured and cause dysautonomia. Along the entire nerve body, you have the autoimmune, the neurotoxins, and the infections. And then finally, from the bottom up, things that are happening at the end organs. And that's where the mast cells and leaky gut and autoimmune issues are affecting the autonomic nervous system. One of my favorite considerations with dysautonomia is something called craniocervical instability. And that's where cervical vertebrae number 1 slips forward because of loose ligaments and compresses vital structures, vascular and neurologic structures. And there's the vascular structures being compressed, and the neurologic structures would be cranial nerves 9, 10, and 11, glossopharyngeal, vagus, and spinal accessory nerves that make up what's called the pharyngeal plexus, that's found just after it leaves what's called the jugular foramen. So this is a very vulnerable site, particularly in patients that have hypermobility and Ehlers-Danlos syndrome, to get what I call carpal tunnel syndrome of the neck, leading to dysautonomia. Okay, so a lot of these patients early on have the simplest of symptoms that would send one to a cardiologist. So it's not uncommon that a cardiologist would see these patients. They're coming in with racing heart, palpitations, shortness of breath, chest pain, dizziness, lightheadedness, near fainting, generalized fatigue, early exhaustion, exercise intolerance, and particularly intolerance in an upright position. Not surprising that they would be sent to a cardiologist, and the cardiologist would work these patients up. But anyone who takes care of these patients knows that this is just the beginning of their symptoms. And oftentimes they have a much, much larger number of symptoms that cover just about every organ system in the body. And so I'm going to help you understand how we get from this, what a cardiologist would be thinking about, to this full-fledged dysautonomia. Okay? And it starts with this concept of orthostatic intolerance. So this idea that in a lying position, a person is fully evenly perfused, and when they start to sit up and stand up, blood actually pools downward. And when it pools downward, it causes head type symptoms. And also, you might notice, looking down, that the legs are engorged with blood. And this is particularly prominent when someone is coming out of a shower, when they're already a little vasodilated from the heat of the shower, and this is even more prominent coming out of the shower. Okay, what is happening at a deeper level, at the cardiovascular level? And this is a core slide. This is one slide you want to remember, and that is The idea that there's a central venous pool that's returning after the blood has given up its oxygen and nutrients, returns to a central venous pool awaiting to enter the heart again. And then when the heart relaxes to open up, to ask for more blood, essentially, that's called preloading. The blood is not there to return to have adequate preload. And if you don't have adequate preload, then the next phase, the stroke, you don't have adequate stroke volume. Your stroke volume falls off, and if your stroke volume falls off, your cardiac output drops. So in a normal adult, 5 liters per minute drops down to, say, 3 liters per minute. And the part that suffers the most is the head, and you get lack of cerebral perfusion. So the consequences of that orthostatic intolerance is orthostatic intolerance and inability to be in an upright position, fatigue, brain fog, and resting and exertional dyspnea. In fact, there was a study done that showed that the chest pain and the dyspnea that patients feel is directly related to the low ventricular filling, this lack of pre-fill that occurs. So you fill the ventricle and you have good stroke volume, and the chest pain and dyspnea will be relieved as well as the head symptoms. Okay, so cardiac output is the stroke volume times heart rate. And so when stroke volume falls off, the body tries to respond to that by increasing heart rate. And so heart rate increases when stroke volume falls off. You stand up, you lose your preload, stroke volume falls off, the body responds by increasing heart rate. But it doesn't matter how much the heart rate increases. The faster it goes, the less filling there is. The limiting rate, the rate limiting step, is how fast blood is able to enter into the right ventricle. And so the faster it beats, the lower each stroke volume. So cardiac output does not respond to heart rate. Nonetheless, heart rate increases. So the consequence of that is a chronic racing heart, as well as bursts of palpitations with any minor activity. So that's where that part comes from. But that's not all. So one question is, why does this venous pool sag away from the heart? And we talk about the concept of the vascular tank, and the vascular tank should have some stiffness to it so that the filling comes up to the level of the heart. And instead, you got sort of a saggy balloon situation going on. Well, why does that balloon sag away from the heart? There's actually 2 big reasons for that. One is dysfunctional smooth muscle vasoconstriction of the arterioles and venules. Okay, so that's autonomic dysfunction. But another is abnormal structural compliance. So we got autonomic dysfunction, but also another part of it is the connective tissue anomaly, right? So that brings us back to this idea that POTS doesn't necessarily, theoretically, doesn't have to be dysautonomia. It could be where abnormal structural compliance alone creates a POTS-like situation that doesn't involve dysautonomia. Now, in reality, it's very, very hard to have structural compliance issues that don't quickly lead to dysfunction of the autonomic nervous system. But it is theoretically possible that, say, a patient with Ehlers-Danlos who has very stretchy venules can have POTS without a whole lot of dysautonomia. And the fact is that the stretchiness, the sagging tank, is a combination of the two. And some patients have more autonomic dysfunction, and other patients have more of a structural compliance issue. And that makes a very heterogeneous population that has POTS, and of course, very heterogeneous way to manage it. Okay, but that's not all. The next thing that happens with these patients is what's called the aldosterone paradox. And that is where there's pooling of blood downward, as we mentioned, and it's down, the pool sits down at the level of the kidneys. So the kidneys actually think this person is fluid overloaded. And so they do what they're supposed to do, they diurese. They diurese because they think the person's fluid overloaded. And so this person who's already dehydrated in the top part of their body becomes even more so. And so the consequences of aldosterone paradox is even more orthostatic intolerance, more fatigue, more brain fog, and more resting and exertional dyspnea, basically worsening orthostatic intolerance from that. But that's not all. The next thing that happens is the patient develops what's called sympathetic overdrive. Their body recognizes a very vital function is not being met in the body. Cardiac output is not adequate. And so the sympathetic nervous system kicks in and tries to correct that. And that's called sympathetic overdrive. And it basically works by increasing the amount of adrenaline at any time in the body. So adrenaline is running around day and night trying to fix the problem of inadequate cardiac output. When you have increased adrenaline, the consequences of that is more palpitations, racing heart, anxiety, insomnia, and subtle hyperventilation, breathing faster than you should. And if you ask these patients, they say they feel they can never keep up with their breathing. They always feel behind. But if you measure their CO2 in their blood, either by end-tidal CO2 or skin transcutaneous CO2, they are actually hyperventilating, blowing off CO2. And the consequence of blowing off CO2 is it puts patients on the edge of a panic attack. They feel the tingling and numbness in their extremities all the time. And that is not far from being a full-fledged panic attack. They get migraine headaches and they get worsening brain fog. This is probably a bigger contribution of brain fog than just the orthostatic intolerance alone. Why is that happening? Well, this concept that the determinants of cerebral blood flow, how much blood flow gets to the brain, is mostly dependent on your carbon dioxide level in your blood. Yes, there's at least 3 different components: mean arterial pressure, partial pressure of oxygen in the blood, and partial pressure of CO2. But over a very wide physiologic range, neither the mean arterial pressure nor the oxygen level in the blood has any effect on cerebral blood flow. This is what we call cerebral autoregulation, protecting blood flow to the head, no matter what the blood pressure or oxygen. But PCO2 is different. There's a wide change in CO2 level and in blood flow, depending on what your CO2 level is. And if you have a change, let's say from 40 millimeters of mercury of CO2 in your blood, you hyperventilate down to 30, your cerebral blood flow drops significantly. And that leads to migraine headaches, and it leads to worsening brain fog right there. So correcting that is important. So there you have it. A saggy tank added to sympathetic overdrive, and you basically have POTS. That is POTS. Another way to think of POTS is it's a pre-heart failure, a failure of preload of the heart. So you've probably heard the concept of the Grinch heart, or the hypotrophic heart of patients that have POTS. And that is just simply not true, that if the heart is the wrong size, it's simply as soon as you add preload to fill the heart, it is of normal size. You may have also heard of subtypes of POTS: hyperadrenergic POTS, hypovolemic POTS, and neuropathic POTS. And these days, we don't really think of hyperadrenergic POTS and hypovolemic POTS as subtypes. Patients may come in and ask you, am I a hyperadrenergic POTS patient, or am I a hypovolemic POTS patient? And we think of these now as clinical states that patients can actually pass back and forth between, depending on how much sympathetic overdrive. If sympathetic overdrive is driving most of their symptoms, then they happen to be in a hyperadrenergic POTS type state. If, however, the hypovolemia, say the aldosterone paradox, is driving most of their problems, then they are in a hypovolemic state. Now, that's as opposed to the neuropathic POTS, which probably is its own individual clinic state. and it's due to injured small nerve fibers that might occur with diabetes or autoimmunity. So I would still call that its own category, its own category. Okay, so how do you diagnose it? Well, the basic thing you want to do is determine whether they have a heart rate rise upon standing. And you can either do that with a head-up tilt table test or just doing a simple lying to quiet standing test, lying, sitting, standing test. And what you want to see is in a lying position, their heart rate may be this, but upon standing, it rises 30 points if over 19, or 40 points if between 12 and 19. But the other part is you want to see that their blood pressure remains pretty stable throughout. If they drop their blood pressure, then we don't call that POTS anymore. We call that orthostatic hypotension. Kind of a different category, even though from a cardiologist standpoint, a lot of the same pathology is happening. It's just, one is compensated cardiac pre-failure, and the other one is uncompensated cardiac pre-failure. Another way, at least the way I look at it, is with exercise testing. And so when you exercise test someone, either on a bike or treadmill, you collect oxygen and carbon dioxide data as well as heart rate data. And one of the important measures is what's called oxygen pulse curve. And the oxygen pulse curve can be thought of as a surrogate for stroke volume of the left ventricle. And a normal healthy person will have an oxygen pulse curve that looks like this on the, left for me. It goes starting at 3, and it'll go up to between 12 and 15 at peak exercise and come down with rest. A well-trained person, that is one of the main training effects, is how much they improve their stroke volume. And so a well-trained person ready for the Olympics might be up at 24, 27. So they basically double their stroke volume over that of a person who's untrained but healthy. And that is in contrast to a patient who has POTS dysautonomia, where no matter how much they exercise and work, their stroke volume can't increase. And that is a direct consequence of lack of ability to fill that ventricle to have stroke volume. That is the lack of stroke volume with exercise. Another thing that I find very important is during an exercise test, measuring that end tidal CO2. And typically this should be 40 at rest before they start their exercise. They get behind during exercise, so it might rise to 44 and end around 42 at the end of exercise. But during exercise for these patients, at rest, they're hyperventilating. This patient's down at 29 for their CO2, not even starting. And then even during exercise, they're hyperventilating. When every one of us else is falling behind in our ability to keep up our CO2, these patients hyperventilate even during exercise. It's very interesting. Another way I look at it is with a Holter monitor that measures heart rate variability. It's very hard to get a monitor a company to get this to do this anymore. One company that did do it was Biotel, and they produce what are called Postural graphs. They've sold themselves to another company, and ever since they were sold, they stopped doing this particular form of heart rate variability. But what we see here is these are beat to beat changes in the rate. And so someone has a very steady heart rate, such as this, they fall right on the 45-degree angle. But if they have a big change, say from this beat to this beat to this beat, they're going to fall way off that 45-degree. And so this would be a typical heart rate variability of a healthy person. However, if you look at, as you get increasing levels of dysautonomia, you get increasing amounts of heart rate variability. And this is sleeping and normal daily activity. So this is a very high heart rate variability in a patient with bad dysautonomia. Okay, so we've talked mainly about POTS, but there is, of course, this association with other entities that you're going to hear about through the rest of the day. Even the consensus papers, both the American and the Canadian Cardiovascular Society consensus papers, are now recognizing what the Canadian consensus position calls POTS plus, and they specifically mention Ehlers-Danlos, mast cell activation, autoimmunity, and other. And so this is what we're going to spend the rest of the time talking about here. So what I have in my schematic here showing is that a patient may begin with pure parasympathetic dysfunction, this saggy balloon, and then they develop the aldosterone paradox as phase 2, as well as sympathetic overdrive. But that eventually leads to what I call the metabolic dysfunction phase, where you have activation of mast cells, leaky gut, mitochondrial dysfunction, development of hypermobility. Some of these patients suddenly start developing hypermobility when they weren't hypermobile before. And of course, mood disorders is another thing that starts to become prominent, not just the anxiety, but depression as well. And then finally, phase 4 is a combination of what I call viscerotosis, sagging organs, really a consequence of the hypermobility, causing sagging organs, including cranial cervical instability, and autoimmunity. And sometimes those autoantibodies are directly against acetylcholine receptors, sometimes they're against other things. Sometimes it's like lupus, Sjogren's, and sometimes it's specifically against the autonomic nervous system. So all this combination has led us to develop this concept called the PENTAD super syndrome. Basically 5 entities that are very commonly seen at the same time: dysautonomia, mast cell activation, Ehlers-Danlos, and these 3 together, this triad, usually leads to gastrointestinal dysmotility, and then often to autoimmune diseases, sometimes early on, very often later on. So you're going to hear from Dr. Afrin next, all about mast cell activation, Laura Pace about the gastrointestinal dysmotility. I think Dr. Burgess later on Ehlers-Danlos, and so we'll get into all of that. But using this concept of the PENTAD super syndrome, it becomes easier to understand what are all these other sub-syndromes that are often found with these 5 basic things. And so you can categorize all these other sub-syndromes in a meaningful way that starts to make sense. For instance, patients that seem to have multiple chemical sensitivity syndrome and CRPS and fibromyalgia, those are patients that tend to have a strong underlying mast cell activation syndrome. Those that have cranial cervical instability and CSF leak and all these things over here on the left side tend to have hypermobility or Ehlers-Danlos. And finally, those who have autoimmunity show different forms of autoimmune issues. So this kind of connects dysautonomia to mast cell activation and GI dysmotility. So there's a direct connection. There's many, many different direct connections, and I give an entire talk based on how these many different connections occur. But this is one particular direct connection between dysautonomia and mast cell activation syndrome. And that is that the vagus nerve innervates the gut, and acetylcholine secreted from vagal nerve fibers actually calms mast cells down and calms down an inflammatory response. And so when it's dysfunctional, you lose that brake on mast cells and you have mast cell activation arising from that. Another way it can happen is what I call the brain-gut axis issue. And that is where you may start off here with pure vagal dysfunction, efferent, meaning out from the brain to the organs, dysfunction, causing both a rise in pH and a slow motility of the GI tract. And that allows the gut to start developing what's called SIBO, small intestinal bacterial overgrowth. And though that issue then activates mast cells on the gut surface. Mast cells secrete things that break down the gut lining, elastases and chimases, breaking down the gut lining, causing leaky gut. And as things pass through to the lower layers, there's more mast cells activated. And these mast cells are now next to the sensory nerve fibers of the vagus nerve, the afferent pathways. And so they become inflamed, irritated, and that basically sends bad signals back to the brain, what we call garbage in. And if there's garbage in, there'll be garbage out. So if afferent vagus nerve is misfiring, it's going to cause misfiring of the efferent vagus nerve. And that doesn't just apply to the gut, it also applies to all the other organs that the vagus nerve is innervating. So heart rate variability increases and blood vessels inappropriately dilate. So now we come back to that slide of all those different symptoms, and you start to understand, wait a minute, this isn't just dysautonomia causing these symptoms. This is also a patient who has mast cell activation, hypermobility, and then some of the symptoms can be blamed on a mix of the three issues. And that's particularly true of the GI tract, whether it's a mix of mast cell, slow motility, and even viscerotosis of the organs that are not in their right place and so don't work very well. So now you can understand why these patients have just about every symptom possible, and they're not just making this up. And it doesn't always just start with a primary vagal dysfunction leading to the pentad. Some patients start off with hypermobility before anything else, and they lead to the pentad, or a primary autoimmunity, or maybe they're very young, develop a GI dysmotility, or their mast cell activation, perhaps either primary or more likely an environmental exposure, activating mast cells. It all ends up leading essentially to the same entity of the pentad, where all these patients act very similar despite how they became ill in the first place. Okay, so rounding up the talk here, it's worth mentioning post-COVID long haul, which I think Mary Claire Seeley will talk about a little bit later on. And so I'll mention that there's a lot of similarities of the pentad with the post-COVID long haul. All these patients that have long haul appear to have dysautonomia mast cell. Some of them have autoimmunity. I think Jill Schofield showed that antiphospholipid syndrome, antiphospholipid antibodies are prevalent post-COVID in long haul syndrome. So there's the autoimmunity portion of it. In addition to that, I think long haul has a very big component of hypercoagulation that may be unique to that. And so patients show up a little bit different with post-COVID long haul because of that. They have some pathognomonic features. And you may be interested to hear some very early breaking news. This was just published 3 days ago. This is a study that looked at protein modeling of the spike protein. And depending on the variant of the protein, how well it binds. Everybody knows it binds to the ACE receptor, but it also can bind to the acetylcholine receptor, and one particular acetylcholine receptor, the alpha-7 nicotinic acetylcholine receptor. This acetylcholine receptor is really important because it is part of what's called the cholinergic anti-inflammatory pathway. A little bit like I mentioned earlier, that the secretion of vagally derived acetylcholine will calm down the immune system, including mast cells. And so this alpha-7 nicotinic acetylcholine receptor is part of that mechanism. These are found on most white blood cells, T cells, B cells, monocytes, macrophages, dendritic cells, maybe on mast cells, but mast cells certainly are affected by the activities of those other white cells. So they're affected as well. And what was shown was that sequentially, these parts of the spike protein sit on this subunit with different affinities. And The earlier versions sat with tighter affinities and probably was responsible for the much higher inflammatory cytokine storms that we used to see in those earlier versions that are less prominent now. And, you know, the explanation being these other proteins just don't have quite the binding affinity that the original did. And that may be responsible for having less of a effect on the inflammatory response. All right, so that's my talk. It looks like I made it through in 35 minutes, so I think I'm good.